All right, good afternoon, colleagues. We'll get started. Welcome to Blood SA Hematology Deep Dive session. For those that don't know me, my name is Helder de Quintal, and I'm one of the pediatric oncologists, also leading the stem cell transplant unit here at the Red Cross Children's Hospital in Cape Town. Today's topic is on the indications for pediatric stem cell transplant in South Africa. The session is particularly meaningful as it reflects a collaborative effort by the National Working Group, of which I'm a part, aiming at improving equity, transparency, and clinical consistency in pediatric transplant through the country. So I'd just like to thank the deep dive management team, Professor Stelfer Berg, Dr. Nicole Smith, and Mrs. Michael Lee Brooks, for allowing me to co-chair this meeting. Some housekeeping rules. The session will be recorded and can be found on the Blood SA website. Please mute yourself during the presentation, but do feel free to add questions and comments in the chat box, and we will respond to those questions and comments at the end of the presentation. Your attendance during this meeting will allow you to be eligible to CPD points. There'll also be an anonymous feedback survey at the end of the session that will be sent to you, which I hope all of you will take a bit of time in completing, as it helps us to improve our presentations and this deep dive. So feel free to provide honest feedback. Some upcoming events that everyone should know about. There's the 2026 Physicians Conference, 4 to 6 June 2026. Importantly, the upcoming SASMO SASETS on the 7th to the 9th of August 2026. There's the 18th Annual Hematology Oncology Conference. It's from the 2nd to the 4th of October 2026 at Century City Hotel. And just a reminder that next week there will be a presentation by David Richardson, Dalian Creel, and Jody Rush, who will be presenting on micronutrient deficiencies, a deep dive on iron and copper. So without further ado, I'd like to just essentially introduce our speaker today. It's with great pleasure to introduce Professor Candice Hendricks. She's a pediatric hematologist and clinician scientist who completed her PhD at the University of Pretoria in 2024, and then was appointed as an honorary professor within the Department of Medical Immunology in 2025. She's the Processing Facility Director at Albert's Cellular Therapy at Netcare Pretoria East Hospital. Africa's first CAR-T clinical trial manufacturing program is underway there. Professor Hendricks currently chairs both the Blood SA SAPO Pediatric Stem Cell Transplant Working Party, as well as the Blood SA Gene and Gene Therapy Working Party, and serves on the Ministerial Advisory Committee on Cancer Care and Prevention. She's working towards increasing access to stem cell transplantation and advanced cellular therapies for South African children. Her international activities also include serving as co-vice chair of the EBMT Trainee Committee, and she's also a member of the EBMT Equity, Diversity and Inclusion Committee. Today, she'll be taking us through a journey of developing the National Pediatric Stem Cell Transplant Indications document, how the working party was formed, why harmonized indications were essential, and how we navigate the realities of transplant decision-making in a highly unequal healthcare system. So Candice, you can take this away from.
Thank you so much for your kind introduction. Let me just share my presentation. Okay, good. Thank you so much. It's such a pleasure to talk to you all today about a topic very near and dear to my heart, and something I've been working towards for many, many years. And part of that is the journey to standardizing indications for pediatric transplantation in South Africa. But I'll really give the journey of transplantation in South Africa to show that we have a long way to go to actually make this therapy that is equally accessible to all. All right, so where it all began is in 1974 at Groote Schuur Hospital, which still remains the major public health care.
Can I just, are you in presenter mode? Because on my
it's it's not? Okay, so let me bring this to this. Okay, now?
That's good. Yeah.
Good.
Thanks.
Sorry, I had multiple screens open. Okay, so the first one was 1974 by Prof. Jacobs, and Groote Schuur still remains the major public transplantation facility in South Africa. But sadly, most of the subsequent growth in transplantation has been in the private sector. So this is pretty much what the transplantation units look like in South Africa. I really apologize if I've missed one or two out, but I think this is almost all of them, with the dark blue balloons being those in the private sector and the red balloons being those in the public sector. But it's also important to note that this is for adults and pediatrics, and that many of these transplant units only perform autologous transplantations and not allogeneic. So even within each sector, there is inequality. So not every transplant center is able to transplant the same types and numbers of patients. So if we look at how many transplants we are actually doing across South Africa, the latest sort of complete list that we have, is from the EBMT survey on transplant activity in 2019. And we've probably improved a bit after this. But if we look at the total number of transplants we are doing, let's say that 157 in 2019. At most, we're probably doing about 200 now. Autologous, we're probably closer to 250. But these numbers still show a rate of the population per annum of 5.6. And if we look at allos in particular, it's 2.5 per million population per annum. And if we compare this to high-income countries in Europe or the United States, they are at 30 per million of the population per annum. So this just shows us the stark reality, and that it's very difficult to improve on these numbers for a variety of reasons. So if we look specifically at the number of pediatric transplantation beds that are available in the country, and this is specifically beds able to do allogeneic transplantation, the Red Cross Groote Schuur component, which is a shared transplant service with the younger kids under 8 being transplanted at Red Cross and older kids at Groote Schuur, they have around 3 beds. Steve Biko Academic Hospital, around 2 beds. Charlotte Maxeke, which has started up their unit in the last few years, 2 beds. And then on the private side, Netcare Unitas with 2 beds, Donald Gordon, about 1 bed, but I think they are definitely increasing that in the next year or so. And then the blood center at Rondebosch Medical Center, we're not entirely sure of the number, but let's say there's approximately 14 beds in the entire country with again, the beds are not equal. Some beds can transplant any patient, some are focusing only on standard risk transplantations. So this just shows us the reality. And a number of people on the working party, as well as the majority of the adult transplanters, at least one representative from the large centers, we were able to publish a paper at the beginning of this year on increasing access to pediatric transplantations. I really want to thank all of them, and I'll be using a lot of the data from that paper in this presentation. The first is that for the first time, we actually had very accurate statistics of the number of transplants that we are performing, allogeneic transplantations across the country. I may have left out 1 or 2 centers here, but certainly 90% of centers doing pediatric transplantations are represented. And Again, if you look here, Grooteskier Red Cross still does the most number of pediatric transplantations with around 8 under 12 and around 5, 12 to 17 years old per annum, so about 13 per annum in that transplantation sector. And then Netcare Unitas here does about 6 per year. The rest are quite scattered, 1 year, 2 there, across all the different centers, which means in total, for the entire country, we are doing no more than around 30 allogeneic pediatric transplantations per year, with a very small number under 12, only around 15. So we really, really have a long way to go. So how many do we need to do? This is really a ballpark figure because we are trying to improve our local registries or requirements for transplantation. This is using international statistics. So we now know that we're doing about 30 pediatric transplants per year. The need is closer to 600. And I get that from the international rates because we have to look at it in 2 ways. The first is that they usually give a ballpark figure of about 4 to 5 per million of the population per annum is the pediatric transplant need. But we must remember that Europe and the United States have about almost half the number of children that we have. So their pediatric populations are around 18 to 20%, whereas we have 36% of our population under the age of 19. So we have about 22 million pediatric patients. So if you look at Europe, they at 30 per million children per annum. Right? And if we take that, then of course our numbers soar. So we know that in our lifetimes, this may not be achieved, but certainly we can do better to put a dent in that number and not hang around at 30. And for adults, I've also taken the 30 per million. So if we're doing around 200, the need is closer to 2,000. So again, I'm speaking about pediatrics in particular, but the need for allogeneic hematopoietic stem cell transplantation is a nationwide problem, and adults are also bearing the brunt of that. Now, importantly, we don't transplant the same types of patients automatically between pediatrics and adults. So on the left, we have a pie chart of pediatric indications, and this is purely for allogeneic transplantation, and on the right is adults. Okay, so malignancy-wise, we're pretty much the same, except that in pediatrics, we do more ALL transplants, and in adults, we do more AML transplants. But I want to bring your attention to the lost cause transplants, which is the non-malignant diseases, which is the red side of the pie of the pediatric side. So here we have your primary immune deficiencies, your inborn errors of metabolism, your hemoglobinopathies, and your bone marrow failure syndromes, both inherited and acquired. And the reason you don't see that on the pie on the right is that certainly the inborn errors of metabolism and the primary immune deficiencies and the inherited bone marrow failure syndrome are all dying in the first few years of life and therefore not alive to be transplanted when they are older. So this is a huge unmet need in South Africa because for identifying them first and getting them to transplant urgently, particularly in the public sector, is something that is completely unattainable at the moment. So if we look at numbers, the number of or the percentage of pediatric patients requiring allogeneic transplantation is 70% versus about 40% for adult patients. So there is certainly a much larger proportion of adult patients where you can get away with just having an autologous program. But in pediatrics, the vast majority of our patients would not be gaining access to transplant if we only run autologous services. Now, this is not news to anybody on this call because we share these barriers and we speak about them ad nauseum. So I just want to run through them quickly in that we have a multifaceted barrier list to trying to improve access to transplantation, and we have to do them all in parallel if we actually want to see this modality improving in our country. We know the national registries is a big problem, and Blood SA is trying to work towards improving this, and even within our pediatric transplant working party, we are trying to get better numbers Because in my multiple engagements with the Department of Health in trying to advocate for improved transplant services, the first thing they will ask you is what is the size of the problem you are trying to solve? And this becomes very difficult. Of course, we have our extrapolated numbers, so we do know that we are doing far fewer transplants than required. But if we don't have accurate data, then we are not advocating properly, and they see that as an excuse. The donors and donor availability, I will spend a little bit more time speaking about in the upcoming slides. Because of the low number of transplants we do, particularly in pediatrics, we have an absolute dearth of skill from doctors and nurses. And many of us that have pediatric transplantation skill, in fact, all of us have had to train abroad, maybe just one or two have received their training locally under the auspices of adult transplantation units. But this makes it very difficult and not feasible for most people to actually move at the stage of their lives to go and get training abroad. And the nursing skill even worse, right? I mean, nurses are the backbone of these services, and we have started a national nursing working party as well to try and address this and to try and formalize our nursing training as well. The infrastructure requirements, if we want to give our patients the best chance, and we are running an allogeneic service, we really know that we should be doing this in pressurized rooms with laminar flow HEPA filtration to minimize the risk of complications, especially infections, because we are not able to treat these infections because of the next problem, which is actually the drugs. So drugs is a multifaceted problem. Many of the transplantation drugs are not registered in South Africa. When they are registered, they're only available in the private sector. And even then, it is very difficult. It's on Section 21 and it takes a long time. So at the time that the patient has the complication, we're unable to provide it with urgency. And then I don't even want to go to the cost. So these are all things that we are trying to address, but it is going to take a long time. Cost effectiveness is also something I'll be speaking about in the next couple of slides. Is this the best way to spend our money for these patients? And then we do know that we live in the most unequal country in the world, which makes this even more difficult because we have 80% of the doctors looking after 20% of the population in the private sector and the reverse in the public sector. How do we overcome these difficulties? Okay, so as mentioned, I just wanted to speak about the donor matter. And this is actually quite good news. This is a paper published by the DKMS group. Many of the people on the call were co-authors here. And it was now that we are recruiting many more Black African donors or donors of color onto our local registries. What are the chances of actually finding a match for patients, especially with our knowledge that we have the highest HLA diversity in the world? Is it possible, like, will we ever reach a point where we actually have a high matching probability? And this is very interesting. So the purple line is Black African patients in South Africa, and the orange line is white South African patients. So as you can see, once you get to around 1 million donors, so 10 to the power of 6, there's an 80% probability of white and Black patients receiving a matching or finding a matching donor. Availability is another issue in and of itself. But it certainly changed our perspective to say, okay, so this is possible. But before we get too excited, we have to realize that in order for that 80% matching probability to happen, we need 1 million available donors that are African Black. And available being the most important word. So even though we have more donors, we are struggling a bit with donor availability, which I know is being addressed. But it certainly means we can work towards a goal of our local patients receiving donor matches. So this is from our published paper showing the number of donors that we have on our local registries and how it has increased from 2022 to 2024. So it has been a great increase. So at present, we have about 200,000 donors on our local registries combined. And of that, this is in 2024, so I know this has improved subsequently as well. Around 50% of those are African Black. And of course, in order for us to gain better access to better donors for our Black African patients, which make up the majority of our country, we need this to reflect our local demographics more. So what would be good in the next few years is to show that 80% of our local donor base is actually made up of African Black donors. But this is an even more interesting slide. So this is data from the DKMS Pediatric State Patient Program. So this is a program initiated by DKMS Africa, where all public sector pediatric patients requiring transplantation would be sent to this program, and that DKMS would cover their costs for available donors. So at this point, so this is also a bit outdated, this is toward the end of last year, this was 273 patients that were sent to the state patient program. All right, so that's the 261 donors of color and 12 white patients and 261 patients of color. So that makes up the 273. The requests reflect our demographics. 88% of the requests in this program were for African Black patients. And what is very interesting is that around a third of these local Black patients received or had a donor match on our local DKMS Africa registry. So it shows that our local Black patients have the highest chance of getting a donor if we improve our numbers on our local registries, because only 5% of them got a donor outside of the DKMS Africa donor base. So I hope that makes sense. And this is quite different. I know these numbers are very small, but because we know that the international registries are also biased towards those of European descent, even if you're a white patient in South Africa and you don't get a match locally on our local DKMS Africa registry, you are almost certainly going to get a donor on another registry outside of the country. But the same is not true for those African Black patients. So we really need to work towards increasing our local donor base and making these donors available, because even these 64 patients could not get to transplant, right? So just to show you, of those 273 patients, let's say 87% of them had a matching donor, either locally or abroad. And of those 87 patients, only 5 patients got to transplant. So this is quite, we're excited for any patient to get to transplant, but it just shows you this middle ground here. What is happening between a patient having a matching donor and getting to transplant? Of course, there are no beds just to actually look after the number of patients that require it. We have a low donor availability, we have progression of disease, but it does show you that the need is there. But the rest of the time, and to actually get a patient from a matched donor to transplant, is the missing link that we now need to work on very robustly. So now that we have discussed all the barriers and become quite depressed, should we even try? And we should absolutely try. I mean, my favorite line is that every life has equal value. And now that we have identified the problems better, so the last couple of years, we've really teased out where the problems are, how to overcome them, what the numbers are better. We have local data for the first time. We really can't sit back and do nothing, because we do have a lot of transplantation skill, particularly on the adult side. And we have sufficient skills on the pediatric side to improve it, not to get to the 600, but we can do better, so we must do better. And I don't know about you, but I am certainly tired of living in perpetual inequality, and now we have an opportunity to do something about it. I also wanted to just bring to your attention, I mean, it's difficult in a country like South Africa to advocate for an expensive resource, right? So does it matter to actually pursue saving these patients? And I've just taken one snapshot. So this is a table from the Great Ormond Street Hospital for Children Centre in London. When London was still part of the EU, it was the premier European Paediatric Transplant Centre. It is still viewed as the premier European Transplant Centre, even though it's not part of the EU anymore. And they provide their statistics on their website about the outcomes of their patients after an allograft. And as you can see here, the outcomes for pediatric patients who are able to receive an allograft when they need it is 80 to 90%. In South Africa, we know that about 90% of patients, if we look at the statistics, are dying if they need an allograft. So this is certainly enough for us to work towards. We know that we don't have access to the same resources or drugs, but can we get to 60%? Absolutely. And this is just looking at two diseases which are probably at the top of the list of patients that require transplant, the one being aplastic anemia and the one being acute myeloid leukemia. Now, in South Africa, where transplantation is not offered in the majority of cases, only about 10 to 20% of children are surviving beyond 5 years. And this is for all sorts of reasons: infections, intracranial bleeds, platelet refractoriness, and it's even worse, like in provinces like KZN and the Eastern Cape, and would be better at Red Cross, for example, because it's about access and actually the socioeconomic status of patients in that province. But if you look at the international data, more than 90% of pediatric patients with aplastic anemia that get to transplant in time survive. And if you look at acute myeloid leukemia, so actually we have some data from South Africa and Africa that 14 to 30% of acute myeloid leukemia patients are surviving. So a very low number. And this is not even just high-risk patients. This is sort of overall. It would drop even more. And if you look at the transplantation outcome for those who are able to access transplantation, it's 60 to 70%. So these are definitely goals that we can work towards. And the reason is, which comes to the cost effectiveness debate, that we do not send these patients home to die once we make the diagnosis. We treat them over the course of the number of years with multiple admissions, treatment of infections. Many end up in high care and ICU. We provide blood transfusions, platelet transfusions. These things cost money and they are futile if the patients are not going to survive. So why not spend the money better to try and save these patients? Certainly, we will have a more than 10 to 20% survival. And this is a very nice poster data presented by Estelle and Tennis at EHA last year that actually shows this. I mean, it doesn't have a large proportion of children that are included here, but it certainly shows you the advantage in South African numbers of performing transplantation for patients with severe aplastic anemia. Okay, so then now that we had the data and we know we needed to do better, how do we actually increase transplantation in pediatrics? Well, the one thing is we cannot do it in isolation and we cannot do it in silos. So we need advocacy. So we need to be able to go to government and funders and say, we have a problem and we know how to solve it, or at least we have the steps to try and solve it. So we needed to collaborate, we needed better statistics, we needed to understand our problems and work together to solve them. And that is how we formed the Blood SA and SAPO standing, which is the South African Association for Pediatric Hematology and Oncology, Pediatric Transplantation Working Party. So we established that in March 2024. And the first mandate was, well, who do we transplant in this very unequal country? Can we at least have a template by which people can refer patients for transplantation? Okay, so this is the map showing the 12 pediatric oncology units across the country, both public and private. And then we have the red balloons being the transplantation centers, both adult and pediatric, able to accommodate pediatric transplants, so under the age of 18, and then the dark blue balloons are the private sector units able to accommodate pediatric patients, but many of those units are adult units, so they're only looking after teenage kids. So very few patients under the age of 12 have got a space to be transplanted. So now from inception, we have 38 members within this working party. Every single pediatric transplantation unit is represented. All public sector pediatric oncology units are represented. And I think almost all private pediatric oncology units. So if you don't appear on this graph, I really want to give an open invitation to you. I think Blood Center doesn't have a representative, and I'm not sure if Capital in Durban is transplanting under 18s, and if there's perhaps another Gauteng center. But we are open to receiving everybody in this working party, but it really gives me great pleasure to say that this is a fully represented working party. There are not 5 of us making decisions. We make decisions together, and that all of us are happy with. So we started with having a terms of reference to say, what are we trying to achieve here? We are trying to say we want to serve as a platform to discuss matters relating to pediatric transplantation in South Africa that can be standardized, that we need a standard. We don't need a private standard and a public standard. We want a complete standard. And we want people to be able to refer patients for transplantation with confidence. That is the first step, identifying the patient that requires transplantation early, and then working towards coordinated management protocols for these patients across the spectrum. Peri-transplant, transplant complications, post-transplant, vaccination processes, etc. We know this is going to take time, but we have made good progress. Okay, so who will we transplant? What's the actual number of patients needing transplant? How do we overcome the inequality? And how do we standardize management protocols in a country where we have completely unequal access to drugs, for example? So what we did since March 2024 is we meet basically monthly. Sometimes we have to skip if we have another conference or December, for example. But basically, we are meeting on a monthly basis, and we have more than 80% attendance at these meetings, which is a huge feat. And I really must thank my colleagues for making the effort to come. So we have detailed minutes of the conversations and recordings of the conversations to ensure that everybody has a voice, and that those who were not able to attend the meeting can look in detail what was discussed. We divided the group into groups of 3 to 4 to discuss specific disease group indications with evidence-based guidelines. So this was not we are doing this, we want to do this exercise. Absolutely everything is evidence-based. What is in the literature? What should we be doing? Because we wanted to get to our goal quicker, we then had a 2-day pediatric workshop where we actually managed to do about 2 years of meetings into 2 days. And when we were ready to go, we said, okay, we now need to engage with a health ethics person to try and determine how do we send out a document that can cover us for litigation, because we know in the public sector and even in many private centers, we are not able to transplant everybody that is on this list because of the lack of resources. We then circulated the final draft for comment to everybody over a number of weeks, and then we released the final standardized and harmonized indications. I think it was actually October, November 2025, sorry. Okay, so this was all of us at the Transplant Working Party. You will recognize yourselves and many of your colleagues here, and it was really a fantastic 2 days of a lot of work. Okay, so this is our first version. This is what it looks like. I have already shared this on the majority of our national WhatsApp group platforms for everybody to read. But I think I just wanted to highlight how we managed to overcome this unequal access principle. And that to say that we have constraints in human resource infrastructure and medicine availability, and that patients requiring transplantation in the public sector will be prioritized based on available resources and will be transplanted at the clinical expertise that exists within each transplant unit and at the discretion of that transplanter. So we also didn't want to bully the people within the transplantation units to say, this is who you have to transplant, when everybody must be comfortable with their level of skill and resources to undertake this. And then to quote the South African Constitution, which gives everybody the right of access to healthcare, which has to be realized within available resources. Okay, we also stated that we want to prioritize patients with either inherited or acquired bone marrow failure syndromes, followed by acute leukemias, then benign hematological diseases, then other transplant indications, and that we would go according to the normal donor hierarchy. First, an HLA identical sibling, then a 10 out of 10 matched unrelated donor, which is different from European guidelines that said 9 to 10 out of 10 because they have the same outcomes, but we have decided to stick to 10 out of 10. And then to say that mismatched and haploidentical donors can only be considered in experienced centers where sufficient GVHD and infection prophylaxis options are available, so that we don't just give a blanket rule to everybody. So this is what it looks like now, sort of the patient identification pathway. Any patient that is referred for transplant can only be referred for transplant by a pediatric oncology unit or an adult or pediatric transplant center. So what we don't want is people in, like general pediatricians, for example, making the decision that a patient needs to be transplanted, doing the workup pathway and sending the patient to us. We want to be the custodians of that process. So if the patient does have an indication per our indications list, you then obtain consent for HLA typing and statistical data sharing. You then do HLA typing, and then the HLA typing service provider. So at the moment, this is DKMS Africa and the South African Bone Marrow Registry. So once a patient is referred to them for HLA typing, they then keep a record of that patient, which is shared to us as anonymized data as the working party. And then, of course, we do a concurrent donor search. And if the patient is not at a transplant center, we know that there's a whole eligibility assessment that needs to be done before the patient is ready for transplant. We had then specific focus statements. Now, we know that minimal residual disease or measurable residual disease testing is heterogeneous across the world, and we don't necessarily, even, and particularly in South Africa, this is not standardized. So how do we go about patients that are MRD positive and that are now referred for transplantation? This is a big caveat to actually overcome. And the first thing is to say that we know different ways of testing are there: multicolor flow cytometry, immunoglobulin or T-cell receptor gene rearrangements, or recurrent genetic aberration. So what should we use? Well, actually, for the purposes of the indications list, what we said is it doesn't matter which modality you are using, but there must at least be a sensitivity of 1 × 10⁻⁴ after induction for you to say that this patient is MRD positive. And then you have to send it to the transplant center, and the transplant center will then be the final decision maker to determine whether that MRD assessment suits the indications for transplantation. And this, I know, is quite small because I didn't want to give you an exhaustive list. This is about a 30-page document that we have released with 110 references. But this is a snapshot of what we've done. So if you look at papers that are published by, for example, EBMT about transplant indications, they'll usually just have one line there: inborn errors of metabolism or inborn errors of immunity, and say standard for transplantation. But what we have done is actually gone into the specific disease subtypes to make it very clear who we are offering transplant to and who we are not. When is it standard? When is it a clinical option? And when is it not recommended? So even patients that are not recommended for transplant are within these detailed lists. So this is just the first page, our inborn errors of metabolism list, to say, okay, these are the donor choices. These are the notes per condition. So any person who is looking to determine whether a patient meets the indications criteria can look at this document, and it provides a detail about who actually requires transplantation. Okay, so within this manuscript that we have published, the Improving Access to Transplantation, we have put forward Nelson Mandela Children's Hospital as the site through which we can improve access, particularly in the north of the country, because they don't yet have an oncology service running, and we know the need is great. They already have an 8-bed isolation facility, which only needs refurbishment within the hospital, and we are well on our way to actually do this refurbishment, because we actually, for the first time, have a buy-in from the National Department of Health. So hopefully in the next few months, I can give very good news in this regard. This is not a short-term endeavor. Even if all things go well, this unit would open in the first half of 2028, right, because of the refurbishment that is required. But we want to split it into 5 public and 3 private beds to run as a proper public-private facility where every patient has equal access to all resources, clinical trials, etc. We would start with 15 transplants per annum just because of the risk of doing too many when the skill is not yet there, because we would obviously need medical officers in this unit that have no transplant experience and nurses with no transplant experience. We want to be able to offer these patients advanced cellular therapies, another pet topic for me, and happy to speak on that in another meeting because that's a whole different ballgame. We would staff it as a high care, and within the unit, there are 2 beds that would be specifically for patients requiring ICU within these 8 beds so that they don't have to go to a general intensive care unit where all the bugs are flying around. 1 nurse would look after no more than 2 to 3 patients, depending on the state of the patient. We want to make it into a center of excellence where we train both nurses and doctors in transplantation skill, bearing in mind that we would be able to go from our largest pediatric unit doing about 8 transplants a year to potentially 45 transplants a year, which means we can start training locally. And it means the need to train internationally is then not required. We also want to make it a research center and try and get international quality accreditation as soon as it is feasible. So very exciting news on this front. In terms of the working party medium-term goals, we obviously want to continue to advocate for increased donor numbers, particularly donors of color, and improve donor availability, because that in and of itself changes our transplant trajectory from having to do so many mismatched and haplo transplants. We want to standardize donor selection based on evidence, especially for mismatched transplants. And I'm not sure if Debbie is on the call, but this is actually what Debbie's PhD is going to focus on. We want to standardize peri-transplant management protocols and the protocols of transplant complications. We then want to create a platform for discussion of patients within the working party. You know, if you have problems, we want to help each other overcome these problems. We want to create a way to refer patients centrally, and we're still working on that, and obtain sufficient transplant data that we can use to advocate. We also want to ensure that those centers that are transplanting, particularly in the public sector, are adequately equipped to transplant the number of patients. So if you have 2 beds, we want to maximize those 2 beds and ensure that at least, say, 15 patients are transplanted within your unit, so 10 to 15 patients per annum to increase our numbers, and that will require improved human resources, nurses, training, infrastructure, and drug availability. Long term, once these databases are up and running, we want to accurately determine the need for transplantation. We want a process of early referral of all patients across the country requiring transplantation. We want equitable access to drugs. And then we want pharmacokinetic and pharmacogenomic modeling. So this is really a hot topic in the world at the moment. And there's substantial literature showing that patients of African ancestry actually metabolize drugs completely differently from patients of European ancestry, and this has an impact on patient outcome. And in the future, it would be wonderful to be able to do a pharmacogenomic panel on patients to determine whether to increase or decrease drug doses. So what we have to be prepared for, in conclusion, is that we have to know that we will have to do more mismatched transplants earlier. Right? So we might start with standard risk transplants, and we want to do that, but we do know that we still have a very low availability of matched unrelated donors. So what should we do in that respect? If you're in an experience center, we should at least say, let's give the patient a chance and give them a mismatched or haplo transplant if you are able to support that patient. We will have to practice the ethical principle of justice and choose the patients with the best chance of survival. We know as South African doctors, we are used to that, and in the public sector, we will have to make this decision to make sure that we are spending our money in the best way. We must leverage the pharmaceutical industry to make drugs more widely accessible and to register more transplant drugs. And we have to start slowly to gain skill and improve confidence, because the last thing we want is start transplant programs too quickly with patients that are too complex and have a high mortality rate, and everybody loses their confidence. And we will have to invest substantial time in training. But what will drive us to continue our mission is that we really cannot accept doing nothing when so many children are dying. And we must try and treat public and private sector patients in exactly the same way whenever possible. We can aim for best practice and we will overcome our barriers. Certainly within the working party, it has shown me that we can work together as a country because Ubuntu is alive and well in our country. I talk about this a lot at international conferences. I am because you are. We have to ensure that we look outside of our silos where we are working. And I mean, hematology is a very difficult discipline. We are overrun with work. And look outside to see how many are not able to access it and how are we going to overcome this. So on that note, I really want to acknowledge all of my working party colleagues, Dr. Boykutso and Mrs. Amofa from Nelson Mandela Children's Hospital, which I've worked with for many, many years to try and get the Nelson Mandela Children's Hospital project off the board, as well as DKMS who are partnering with us there, all of my co-authors on the paper, and particularly David Britton and Michael Pepper, who were with me from the beginning when we started writing this paper probably 5 years ago and started thinking about how to improve access to transplantation. So I thank you very much, and I am open to any comments or queries or questions.
Thank you, Candice. So thank you for covering such a broad topic so succinctly. Very nice. Thank you. I don't see any questions in the chat, but feel free to just open your mics and ask questions or raise a hand and ask a question if there's something that you want to know. So just a question from me, essentially, how should a clinician use this document, this indications document? Do we use it as a strict gatekeeper or as a guide to a structured clinical discussion? I mean, do you foresee that in future we would have a central review panel that we guide all referrals through in the future?
Yeah, that's a very good question, and I think it's very important. I mean, we're taking baby steps towards our ultimate goal, which would be that all patients, so all pediatric oncologists or hematologists on the pediatric side now, would refer patients, would use this document to refer patients to a central panel, right? And we would meet monthly. And this is particularly useful in the public sector where we should all be working together to try and advocate for the patients with the highest chance of survival of being transplanted. So, for example, you shouldn't be transplanting inborn error of metabolism with a haplodonor if there is a severe aplastic anemia patient with a matched sibling donor. That patient must get a transplant. So we certainly want to work towards that. And the necessity for this document is that even within our pediatric oncology community, sometimes it's difficult to decide who needs a transplant and who doesn't. You know, I'm sitting with this patient, I'm not sure if the MRD meets the requirements. I'm not sure if this patient with this donor would be a candidate. And we really wanted to create a safe space. I mean, allogeneic transplantations is not something that many people know about in the pediatric space in South Africa. Those of us who know more should be the custodians of that space to actually also be educating and teaching our colleagues to say, okay, now I get why you referred this patient. The reason we won't consider this patient is A, B, and C, rather than people keeping the patient until it's too late. So what we want is the comfort to refer the patient earlier rather than later, right? So that we're not sitting down the line with a patient that now becomes very difficult to transplant.
I think I also want to just reinforce the importance of early referral. Of getting patients three cycles down the line being referred, and at that point, you know, with the bed capacity issues that we have, to try and fit a patient so late into the transplant service is almost impossible.
Yes, absolutely, absolutely.
Is there anyone else who have any questions that they want to ask?
Estelle came on there.
I'm trying to get on. So it's great to see our transplanting network in the meeting today, also from the PEDS side. Yeah, it's lovely and it's incredibly encouraging. I think 2 years back it was just a dream, and now it's becoming a reality. Yeah, as adult transplanters, Helder, what are we? Adolescent transplanters.
Mm.
It is, what a good time to transplant a patient than when they are young. And I saw on your diagram, you had this nice thing about how much we should have. And there is, I think, 6 times too little adult transplants, but 20 times too few. So it's by a factor of 5. It's much, much worse for kids. And they respond so well and they do so well. So I think if there's just from our side, and you part of that, Candice, and all of us, are part of it, we're trying to work on the aplastic anemia as a prototype.
Yes.
I think it fits these things. It's rare. It is rare, but it's not that rare. It is it's a shared disease of kids, adolescents, and adults. They cost a lot to the system if there is no transplant.
Yes.
So you can just as well work out what it would cost to the system to actually cure them. So these are things that we're doing, and we hope that it's going to be moving more towards Gauteng, but watch this space, that we will have more of a capacity.
Yes.
It's just, I think it's a wonderful, wonderful privilege, and it is made possible by so many doctors across the country who truly are doing immensely amazing work in difficult circumstances. So if there's anything I can say today, it's that, may that grow. And just one other thing, we actually started on working on it with your colleague, David Britton, regarding the transplant referral page, but we realized that it's much more a page that's important for public service than for private. For private, yes, it's important, but not so much in the early stages. For us, it's quite important in the early stages, the first referrals, the awareness, all that type of stuff. So that's something we can continue working on. It's kind of a new idea now. So let's finish that one too, making it a bit easier to refer.
Absolutely. I think we are. I'm waiting for the adults to also be forming their working party. I know we've discussed it a lot, but I think the purpose is that these documents would now be used as the template to send to government as well as private insurers, so that the private insurers cannot say, but this unit is doing that, so why do you need this additional drug? Which often happens, that we say this is the minimum requirement when you want to transplant this particular patient, and we want to treat the patient like that, whether it's the private sector or the public sector. Which obviously, we do so few pediatric transplants at the moment that many of these diseases have never been transplanted in South Africa. By the time the patients are coming, they're at death's door, they are completely colonized, we can't give them a chance. And we really want to improve the confidence with which people say, okay, no, at this point, this patient has this, I need to refer immediately, rather than doing your own workup, your own HLA typing, getting the result, transfuse the patient 15 times, and then referring. So I think that is probably one of the biggest takeaways, that we can do more when the patients present earlier, and that we as the transplanters must create the space for people who perhaps don't know whether a patient meets the criteria to rather refer and to be told, okay, not at this stage, tell us again in a month when this and this and this happens, rather than waiting for prolonged periods of time.
Yes.
I see all of my transplant colleagues are here from the working party, but they are silent. Silence is golden.
So maybe you just want to mention to the people who are not in the working party group what we're currently working on. So future work. You did touch on it.
Yes. So we are well underway to actually, I hope, by the end of this year, release the peri-transplant management protocol. So what that means is the conditioning regimens, the infection prophylaxis, the immune monitoring and the chimerism monitoring, standardizing that at exactly the same times for all disease conditions. And we hope to release that for severe aplastic anemia, acquired severe aplastic anemia, ALL and AML by the end of the year. So we are trying to have another short workshop to try and get on top of even complications, for example, management of ABO incompatible transplants, management of viral infections, sort of when to do the viral loads, when to act, so that we all do things in the same way. And in that way, we are advocating for each other, right? To actually make these drugs more widely accessible. And yeah, so if we can do that by the end of the year, then I can retire and Helder can take over next year.
We'd like to do that. So I see Taryn just posted in the chat essentially a brief survey. It's a Google form that can just be completed. So people that have attended, it would be useful for you to just provide your honest feedback on this session. And so then I guess just on some closing remarks. So thank you, Candice, for a clear, thoughtful, and an honest account of this journey. What comes through strongly is that this is not just a document of indications. It represents a collaborative effort from all of us, a shared commitment to doing the best for our children under the realities that we are facing every day in South Africa. The strength of this work lies on not only science, but on transparency. It brings together decision-making and creating a common language between referring clinicians, between the transplant centers, and hopefully between the funders. And so we look forward to the next phase of the working party's work, particularly around harmonizing the conditioning protocols and the supportive care that would follow, as you just mentioned. And I just want to thank you, SAPO, and to thank Blood SA and all the clinicians who've contributed to this consensus effort. And thank you to the audience and for the engagement in today's meeting and the ongoing commitment to pediatric transplant in South Africa. And not to forget next week's deep dive session on deficiencies, the copper and iron deficiencies, and a deep dive at that.
So I also just want to say thank you for chairing in such a lovely manner, Dr. De Quintal. We appreciate it, and I really want to thank all the working party colleagues that came onto the call today. It's really a group effort and a shared celebration. I know I chair the committee, but it really takes a lot of effort. We know we are very busy, and the attendance at meetings is outstanding, and just proves the commitment that everybody has to learning within this field. And I can't wait to see what we do together over the next few years and transform the landscape to take the 30 maybe to 80. I mean, that's the short-term goal, right? So it would really be fantastic if we are able to see that.
Hear, hear.
Yeah, that would be amazing.
Thanks, Candice. It was great to listen to you.
Thank you for the opportunity.
Thank
I
you,
appreciate it.
Thank you, guys. Bye-bye.